I'm just going to cover in 25 minutes what's known about the clinical features and clinical care of patients with Ebola. And so it really is a clinician's talk, but I think it needs to lay the basis. It's also one, I really feel like a chancer because I have not actually looked after a patient with Ebola. And in effect, what I'm talking about is derived from experience reported from what might best be summarized as primitive healthcare, where what should be on offer in a developed healthcare system is largely not on offer. It's also derived from, for example, work that's available, a lot of work that's gone on over the past 30 years in experimental medicine, in research and so on, some of it driven by concerns about bioterrorism. A lot of money is being put in to researching these viruses. So I'll touch on virology, pathology, and pathogenesis insofar as we can infer things from it about clinical care. Diagnosis is straightforward, clinical features, transmission a little bit, and then treatment, standard treatment, and then experimental treatment, or the hope that we have of what's published and likely to emerge in the coming year or two. So as Darina outlined, the virology, we're talking about the filoviruses of Filoviridae, Marburg virus, and 5 different types of Ebola virus. In practical terms, 2 different forms of Ebola virus, Sudan Ebola virus and Zaire Ebola virus, which is the cause of the present outbreak, as outlined. It's a filamentous enveloped virus. It's an RNA negative sense. It's uniform diameter, 80 nanometers, 600 to 1400. It's like a snake. It's got 7 structural gene products, 19 kilobases in its gene, and we recognize in these 7 structural proteins a bunch of nucleoproteins, but in particular, in terms of potential future therapies, a glycoprotein, this one here. And also, this glycoprotein is also a non-structural protein that is soluble, a form of it is soluble and secreted. And in terms of invading the cell, this glycoprotein is important in proceeding to the invasion. So it basically touches on the cell, which is generally speaking a macrophage or macrophage line cell, and basically its envelope is there. It's enveloped again by an early endosome onto a late endosome, and this glycoprotein, undoing this glycoprotein is 2 components, GP1, GP2, by proteases that are in endosomes, will be important in allowing these envelopes to unfold and the virus to proceed in terms of its effect. There is some, for example, tentative evidence that the anti-malaria drug chloroquine needs a lot more research, might interfere with this, but no actual data on it. In terms of pathology then, this is essentially studied in monkeys. Virtually all of this is, and what I have to say is studied in monkeys and derived from monkeys, and insofar as monkeys are like humans with regard to Ebola, and they probably are more or less like humans with regard to this, then we derive this. So the primary cells infected are dendritic cells, tissue macrophages and monocytes, also endothelial cells and fibroblasts, hepatocytes, splenic red pulp, and adrenal cortical cells. So in the limited number of postmortems that have been done, there's foci of necrosis in these cells. And so, for example, there's the intriguing possibility that when people are in shock, that there might be some degree of adrenal insufficiency. Not proven, not studied. There's also cytokine release, and this cytokine release increases the recruitment of macrophages and monocytes, and therefore there's increased viral replication in these cells, transport to local lymph nodes and spleen. The lymphocytes are not infected, but there is rapid loss of lymphocytes through apoptosis, through some secondary phenomenon, and this causes a secondary immunosuppression. So as people get into the illness, they become intensely immunosuppressed, and therefore secondary bacterial infections are recognized as a major problem, and also secondary candida infections of the oropharynx and the esophagus is well recognized clinically. There's an overexpression of factor 7A or tissue factor. That may be the cause of DIC. There's also an decrease in protein C levels, and these are possible things that could be attacked therapeutically in terms of replacement to tide a person over under some circumstances. And these give rise to the hemorrhagic manifestations. Now, you all may have noticed that we've abandoned the term viral hemorrhagic fever, and that's to emphasize the fact that it's only in 50% of people is there bleeding, and generally speaking, this bleeding is minor. It's only in perhaps 5 or 10% of people that bleeding is major. And so the term viral hemorrhagic fever is to some extent a misnomer, and we are encouraged to abandon the term. In terms of the pathology, at the Kikwik outbreak in Zaire, or the Democratic Republic of Congo in 1995, a WHO group looked into the idea of skin biopsies as a way of diagnosing Ebola virus, because it could be done safely by putting them in formalin. Now, this is no longer of use for diagnosis, but this biopsy does illustrate the point. This is the dermis here, and this is the epidermis, and you can see in this immunofluorescence study that it's absolutely teeming with viral antigen, vast quantities of it, and some of it spilling into the epidermis, and that's presumed to be Langerhans cell. And again, down here, vast quantities of it in the dermis and surrounding this sweat gland. And in higher magnification, again, you can see vast quantities of virus around sweat gland, and I'll come back to some other evidence that suggests that virus is substantially in sweat, and that might be an important way of why this virus is transmitted apparently through direct contact so easily compared to viruses, for example, such as HIV or hepatitis B, which are not so transmitted. You can safely shake the hand of somebody who has hepatitis B or HIV. You apparently can't do so with Ebola. And so again, this is a sweat gland at higher magnification, and you can see some virus involving the sweat gland directly. And this is an electron microscope, and I won't actually go into this in too much detail, except that it is in fact teeming with active virus in dermis, in extracellular tissue of dermis, and also in cells passing through it. Like any infection, you have an antibody response. And this is the Thai forest Ebola virus infection, which occurred in a zoologist studying an outbreak in chimpanzees in Côte d'Ivoire, previously the only case of Ebola virus in West Africa, and this occurred in 1994. And she was evacuated to Switzerland. The diagnosis was made late into her mystery illness, okay? And basically at the beginning, you have plenty of antigen on day 3 and day 7, okay, by the older tests and antigen detection, the mounting of an IgM response, and then later on day 22 and 42, the mounting of an IgG response, and the antigen going away. And she survived that infection, and essentially by somewhere between day 7 and day 22, the virus disappeared from her system. Now, in terms of pathogenesis, why does it overwhelm people? Why do some survive? It seems that 60% die, 40% survive. Well, there's a failure of the innate immune system. The innate immune system is the initial response, the macrophage response to a viral infection, if you like. Interferon induction is suppressed by one of those proteins. Interferon action is blocked by another. And so there's no resistance to viral growth in the first 10 days. You have, if you like, an exponential growth in virus. There's no activation of killer cells, macrophages or dendritic cells. And it's a race against time as the viral load increases, waiting and hoping, if you like, for the adaptive immune system, that is the antibody and T-cell responses, and especially the antibody responses, to kick in. And that adaptive immune system kicks in at about day 10 or so. And day 10, if you like, is a crucial point. There's no enhancement of adaptive immunity, which normally dampens down the growth of another infection. There's apoptosis of lymphocytes and therefore immunosuppression. Secondary bacterial and yeast infections are important. It's a race between the virus and the adaptive immune system. And therefore, perhaps we could help it along with experimental therapies that actually act on those two things. So why does the patient get shock? Well, there's viral infection of endothelial cells, and there's a vascular leak phenomenon. That is that the fluid that should stay in the vasculature goes into the tissues, so-called third spacing, and this is likely substantial. So the patient's weight actually increases, and they get edematous. There is also correctable hypovolemia because of GI losses, because the immune system along the GI tract is infected, disease develops there, gastrointestinal symptoms develop, vomiting and diarrhea. And the GI losses are of the order of 5 to 10 liters per day. So if you're to help a patient survive, you have to replace and catch up with previous losses and match the losses that are occurring on a given day. A very aggressive fluid response is required. There's no evidence of myocardial dysfunction, but there's not very many echoes, and there's no Swan-Ganz catheters that have been cast, okay? And there's the possibility of adrenal insufficiency, and there's debate about whether excessive cytokines are important or not. The diagnosis is straightforward. The lab might not say that, but from our point of view, it's straightforward. We send a sample to the lab, and they produce the result in 6 or 12 hours. And it's a PCR test. The National Virus Reference Lab works very well with us. It has a 24/7 on-call system, which I'm sure they'll describe later. It can be activated after senior consultation, after a risk assessment, with transport of the sample by a contracted company. They run 2 assays. There are, of course, other things that can be done that we're not doing: virus isolation, electron microscopy, and antibodies and antigen. There's a differential diagnosis for somebody who arrives with a fever, gastrointestinal symptoms, and coming from one of the 3 countries. And the list is extensive, and I won't go into it, but the traditional teaching in infectious diseases is that anybody returning with a fever from the tropics has malaria or typhoid fever until proven otherwise. Those are emphasized for teaching purposes, not because they account for so much as the majority of cases, as these are the life-threatening things that require specific diagnostic tests to look for them, especially malaria and Ebola, but also HIV-related things: HIV seroconversion, AIDS itself, hepatitis, dengue, influenza, and then this list of sometimes rare and sometimes not so rare infections that can arise in such patients. Now, on to nitty-gritty about clinical features. This is hot off the press to some extent. It's New England Journal of Medicine. We joke about that and say it must be right. I suspect the New England Journal of Medicine are actually taking papers, any old paper will do, from West Africa, so I'm not so sure. But this paper is from a group in Monrovia, and they describe a more credible description than one which occurred a few weeks earlier. And they talk about phases of the first phase of 0.0 to 0.3 of fever, and most patients have fever, but it's worth emphasizing for the first half day or day, you may not reach 38 or 38.5. I think that was a problem in assessing the nurse in Madrid in the first day or half day. But generally speaking, people have high fevers, and they have non-specific malaise, fatigue, and body aches, and that could be any diagnosis you like. Okay? Now, during the first 3 days, though, the PCR in general will be positive, but it may be negative. And where there is a suspicion, if you want absolute ruling out of the diagnosis, you may, for some cases, have to have the test repeated if you're within the first 3 days of symptoms. Then between day 3 and 5, gastrointestinal stuff starts to increasingly dominate, with epigastric pain, nausea, vomiting, and diarrhea. And then on the 2nd to 12th day, headache, conjunctival injection, chest pain, abdominal pain, arthralgias, myalgias, hiccups is a kind of a relatively specific symptom and occurring in a significant minority. Delirium, which may be hypoactive or hyperactive, just like somebody who's in alcohol withdrawals, if you like. Agitation might prove a practical issue for dealing with a patient that you're trying to get to comply with rules of isolation. Seizures, lethargy, and prostration. Now, I emphasize that this is the description in a situation where somebody's becoming increasingly dehydrated and not getting an aggressive fluid resuscitation. And that isn't necessarily the case that might occur if these were being counteracted. Viral load is mounting up, this time from lower levels up towards 10 to the 5 to 10 to the 8. And then for the patient who is going to die, the 60%, a thready pulse, hypotension, cold extremities, tachypnea, oligoanuria, decreased consciousness, and coma, all presumed due to hypovolemic shock and lactic acidosis, leading to death in the absence of an aggressive critical care response. And at that stage, high viral load, but viral load which is also dropping. In other words, the tragedy here is that these patients may be dying in front of your eyes, but the virus may be clearing. Or they may be recovering with some complications. And again, at this stage, the virus becomes negative by PCR, but remains positive in semen. Oral esophageal mucosal candidiasis, oral ulcers, secondary sepsis, pneumonia are possible. We might emphasize that there's no real respiratory involvement here, and therefore it's very likely that there is no respiratory transmission because there's no primary viral pneumonia. But you may get secondary bacterial pneumonia at this phase. What's also described less commonly is a syndrome of encephalomyelitis, which is not properly understood, occurring in a minority. Patients apparently recovering, getting neck rigidity, decreased consciousness. Do they have bacterial meningitis or viral meningitis or post-infectious encephalomyelitis? No scans, no LPs done to bring clarity to that yet anyway. And then a few weeks into it, they may get uveitis, orchitis, prolonged weakness and fatigue, and this may persist even for months or even years. And again, this just illustrates it more diagrammatically. It's the same thing again in terms of different phases, a bad outcome or a good outcome. It's the same thing with the virology here. And I put this up to emphasize the laboratory findings, which are of some use. Drop in platelets, but typically not a spectacular drop, typically a platelet count of 100 to 50. Leukopenia, leukocytes rising later, raised transaminases along here. Now, I'm just going to touch on, so what experience do we have now in the developed world, where you max out on your responses? I was at the Philadelphia infectious disease meeting where the two cases that were dealt with in Atlanta, in Emory University, were described. And the Hamburg case, which occurred in August, has been described in the New England Journal of Medicine, and it's best to describe the Hamburg case because we have the data. And Brian Marsh, my colleague in ICU, is going to go into it in more detail. But this was a 36-year-old WHO epidemiologist who was working in Sierra Leone. And on the 18th of August, which was day one, he didn't have fever, but he had myalgia, headache, malaise, and arthralgia. Day 2 to 6 fever. He was treated as malaria and as bacterial infection with ceftazidime, getting increasingly worse. But by day 6, his diagnosis was confirmed. And day 7, nausea, vomiting, and diarrhea were beginning to dominate. He was getting citronmetronidazole, some IV fluids, the amount of which was not specified. It looked like he was dying, so he was transferred to Hamburg. And on admission there, he had fever. He had a blood pressure, and his heart rate was surprisingly normal, but he was clinically dehydrated. His only relevant past history was chronic hepatitis B, which was not causing him any difficulties. He had hemoconcentration, presumably from dehydration, with a hemoglobin of 18, a creatinine of 170, potassium that was down somewhat, but this again will not necessarily reflect total body potassium stores. Transaminase of about 1,000, hepatitis B perhaps contributing to that as well. Platelets down, but not much. D-dimers up in the sky, reflecting a DIC process. And an ultrasound of the abdomen showed complete collapse of his inferior vena cava, a more sophisticated way of assessing his dehydration. He had paralytic ileus, severe edema of the small and large bowel. Now I'm going to talk about experimental treatments, but a lot of them are oral. In fact, most of them are oral. So giving an oral therapy here is irrelevant. So if you were to give such an oral therapy, you'd like to see the patient diagnosed and in on day 3 to 5. And if your oral therapies are going to make a difference, they're going to be practical at that stage. Now, you can read this, but I just put this up from the paper, take it out of the New England Journal of Medicine, please. But what's spectacular about this is the amount of volumes of fluid. These are the days in the Hamburg unit from day 10 on to about day 20-something. And the volumes of fluid, 7 or 8 litres, 13 litres, 11 litres, and so on. Now, Brian Marsh will go into this in more detail. He's promised me he's extracted that data to make it more absorbable. But I want to show his virology. By the time he's arriving, he's improving. He's got virus of 10 to the 8, and then it's down to 10 to the 6, and it's plummeting in his blood. So his immune system is working, it's clearing, but he's still dying in the absence of some form of critical care response. So down it goes, and this in fact is a white cell elevation indicating a secondary bacterial pneumonia. What's also interesting is that they looked at PCR not in blood, but also in urine, and you can see the urine is leaving at a much lower rate. What's really interesting is sweat remains positive. Okay, 10 to the 4. Even though he's gone from the blood, there is still some detectable virus on his surface. Now, whether that detectable virus is all dead or alive and infectious, we don't know. Now, on to the last segment, monitoring and treatment. I'll call it standard and experimental. Anything I say about experimental should be taken with a grain of salt, a very large grain of salt, and you can prove me a liar about it next year or the year after when stuff comes out showing it works or doesn't work. But obviously patients will need a Foley catheter, very likely an NG tube. Some of them will require a rectal tube if they are having torrential diarrhea in terms of, for as much practical infection control reasons as much as for monitoring reasons. Non-invasive BP monitoring, heart rate, respiratory rate and temperature, and O2 SAPs will need to be monitored. In terms of blood tests, and Body Gorman will talk about this later, in our unit and in many units worldwide, bloods will be done point of care, although in principle they can be done in a regular lab because this virus will be inactivated by normal things that the labs use. It's thought to be best to keep the virus strictly within the unit by doing point of care testing. And urine electrolytes, lactate, pH, PO2, PCO2, full blood count, prothrombin times LFTs. And to do one test which will have to leave, of course, will be Ebola virus PCR. And having some repeat testing in the National Virus Reference Laboratory will still be necessary if we have a case. We still haven't sorted out how we're going to do portable chest x-raying, but that will be important in terms of the iatrogenic fluid overload, secondary pneumonia, and I've mentioned the ultrasound already. Standard therapy, 5 to 15 litres per day, perhaps, IV, PO, electrolyte replacement, nutrition, antimicrobials, and transfusion of various blood products are obvious. In terms of untested treatment, the first thing to consider is convalescent serum or blood. And we're not sure whether this is readily available, to what extent this is available. The evidence, 2 years ago, we had a really interesting talk from a man who got Ebola virus during 1976 from a needle stick injury in the laboratory in Portadown. And he survived it, but he survived it with some interferon, which we believe is useless, but also convalescent serum from another case that was given early. And his viral titers went from 10 to the 4 to the 5 down to very low levels. So that's one case. He might have survived anyway. And then in the Kickwick outbreak, you had 8 severe Ebola patients late on received transfused blood from 5 people who had survived with convalescence. They were positive for IgG antibody and negative for antibody. They had only 1 of the 8 die for a 12% mortality compared to an 80% overall. Make of that what you will. Was it due to the intervention, or was it due to the fact that general standard of care was higher from the WHO team? More importantly, in experimental monkeys, volunteer monkeys if you like, polyclonal serum from monkeys who have survived the infection consistently protected other monkeys who were when it was given correctly enough to give adequate doses and dosed well, given at day 2, 4, and 8. 100% survival for these monkeys. So that's the proof of concept that it works. So what do? We try and get a monoclonal antibody. Okay, and there's been 2 lines of research, one called MBO-003, the other ZMAB. I'll rush through these in sense of time. We've got antibodies from these that have been worked out on monkeys and guinea pigs, components worked out, which is good, which is not so good, and then a combination of the 2 called ZMAB with a proper half-life for humans, and then a production system in tobacco plants, individual components put together, and basically tested in monkeys, and tested at the right time, which is 5 days into the onset of symptoms, which is the realistic time for humans, okay? All the monkeys survive compared to the controls. It's a super treatment in monkeys given 5 days into symptoms. And therefore it is the one which is a lot of hope attached. The problem is production. Okay, but the New York Times tells me that sometime in 2015 there'll be a fair amount of it around. So I'd be hopeful that if we have a case in the middle of 2015 that we'll have this. The next thing is antiviral drugs that stop the virus multiplying. And there's a drug called brimcidofovir. Cidofovir is an antiviral that may be familiar to those in ID, but it's a very toxic drug used for CMV. But this is a new drug which is available and being studied for bone marrow transplantation. It is broad spectrum against a variety of viruses, including Ebola virus, in the lab, but not published. And it's a prodrug of cidofovir that's non-toxic for various reasons. But its main adverse effect is diarrhea and vomiting. And the problem is it has to be given orally. So if brimcidofovir is to make a difference, you'd have to have your case early, have to deliver it early. It is an experimental drug. The only way you're going to have it on site is to be part of a trial. We hope to be part of a trial, so we can give brimcidofovir early. There's also another drug called Avigan is the trade name. It's a Japanese product. Fujifilm own it. It's available through Japan. It's approved for use in studying humans for influenza. Been used in about 1,000 people. Got used in a French nurse who survived it. If you want to get it, you call the embassy of Japan. It starts from there. So I think there'd be a delay on this one. There's other therapies, a thing called TK Ebola, which in healthy volunteers is kind of seems like it might be dangerous. And there's this intriguing possibility about chloroquine. So to finish up the issue of prognosis, mortality is 50 to 70%, but Dr. Fowler, who's an intensivist, reported 43% mortality with a good effort at hydration, with rather simple hydration measures down there. My suspicion is that mortality could be put into the 15 to 25% with a really aggressive approach. That's just a gut feeling. But age is the important prognostic factor in Africa. And if you're under 40, it's a 20% mortality in Africa. If you're over 40, it's 80%. So, so I certainly fall into the second category. It's very likely that pregnancy and other immunosuppressive conditions worsen prognosis. And with that, I'll finish up. Thank you.